When a brand new patient comes to me, the first thing I want to do is find out a little bit about their medical history. What brings them to me? What kind of problems have they been having? Or if they don't know any problems, how long they've been trying to get pregnant and have been unable to do so. So we go through a very detailed medical history, family history, social history, and I try to find out a little bit more about that person in particular, what their habits are, what they've done in the past, what they've done to try to promote conception. And then after that's all done, I set up a group of tests to try to fill in the gaps. So there are four main components to reproduction. One is sperm. There must be an adequate number of sperm and sperm of sufficient morphology and motility to be able to fertilize the egg. There has to be a uterus that can accept the embryo and allow it to continue to develop and grow into a baby. There has to be open tubes that can pick up the egg, and fertilization occurs in the tube, so the tubes have to be open, not diseased, and able to incorporate all those processes that allow fertilization in the tube and then transport of the developing embryo back into the uterus. And of course there have to be sufficient numbers of eggs. So a woman who doesn't have sufficient numbers of good quality eggs is also going to have difficulty getting pregnant. So we target our tests on looking at each of those four components. After we finish the testing and we discuss the results of all the tests with the patient, we talk with the patient and we try to determine what's best for them. What are their goals? What do they want to achieve? Do they want one child? Do they want two? Do they want three? And that's very important because women present to us in different stages of the reproductive life. Some come at the very end when we have to get what we can because it won't be possible to get any more pregnancies in a year or so. Some come to us very early in the process, in which case we have plenty of time and we can be a little bit more conservative in getting their families. Some people want only one child. We don't have to worry too much about doing a process that doesn't work as efficiently as others because we have time to spare. If we have no time to spare, then we want to go to a more aggressive approach to try to get them their pregnancy while we still can. Once we've identified the particular problem after a patient's initial evaluation is complete, we target treatment for what isn't working. So for instance, if a patient has sperm that don't function very well, we might want to take the sperm and we might want to concentrate it and do intrauterine insemination. If a person has tubes that are blocked, we may want to do in vitro fertilization, where we take the eggs out, fertilize them in the laboratory, and then put the resultant embryo back into the uterus, thus bypassing the tubes. So what we try to do is target the treatment to fix what's broken. It's theirs. We determine what the different treatment options are, but the patient determines in what order they want to pursue them and which ones they want to go first and which ones they would prefer to do last if the first ones don't work.